My name is Ade Williams. I'm a pharmacist. I spend most of my time in community pharmacy. I am an independent prescriber as well in general practice, and I do have a governance role in acute care and also in mental health and community services. The community pharmacy is very much the heartbeat of primary care. It is also where most of the pharmacy profession practices. The key thing about us is that we work in a shell that is a commercial premises. But the beauty of it is that we are the most accessible part of the NHS. Over 12,000 of us are there. And in that space is where we become almost this sort of the bastions or almost the outposts that everybody can step into and know that they are in receiving NHS care. Now, with our work around oncology, there is certainly a lot to improve on, sadly. And I think that is because the nature of the practice and the nature of our profession tends to be that many of us kind of go off into specialties. And what we then don't do so well is that we are not able to bridge across our own profession to look at how we can collaborate and innovate to deliver the best care in a way that means that we are optimizing patients' outcomes. A lot of the time, that could be just simple patients who are starting medication. So we're talking about things like medication optimization of cancer treatments and chemotherapy therapies, but also a key part of where I really feel that the whole system, and this is not just fellow pharmacy professionals, but really both strategic thinking and also clinical planning loses out on, is the key importance of community pharmacy with regards early diagnosis. We know that the most significant factor in terms of saving lives and better treatment outcomes is early diagnosis. And we know that the first place that people will go to when they do have any sort of worrying symptoms or even symptoms that they think is normal to seek over-the-counter therapy is community pharmacy. So if community pharmacy does not become the beginning of that clinical pathway in an evidenced manner and in a way that allows for a capture and also a tracking of the patient's journey, we are then finding out that latter presentation and latter diagnosis is that failure. And that is, something that is the state. So that's really a bit about me and a bit about some of the things that I think are very important for us to improve on. One of the things that we're putting together is we are also working on a research proposal at the moment, actually, which is looking at working with oncology specialists and general practice and pharmacists to look at how do we design a pathway for referral. That doesn't mean that one is evidence-based and efficient, but also does not have those unwarranted effects whereby you're pushing somebody else somewhere is being drowned by the good work that you're doing and they are having to, and so we'll bring everybody together because our system, because they're not very joined up, what happens is something which is good happens somewhere, but for somebody else, it becomes a bit of a nightmare and they don't even know why. All of a sudden, they've just got all of these referrals turning up, so we are looking at that. And I think that's really also about how we embed, it's not just about being the advocacy bit and thinking, we need to get pharmacy to be part of a pathway, but how do we do things in a way that everybody's got a clear line, everybody has a say. So when you get to the end of it, you are doing the good, but nobody feels as if in that good that has been done, they've become the collateral damage. Their workload is tripled just so that you can now help your own patients better. So and I think that's something as well. And it's really also about co-designing together across the specialty and actually following the patient's journey. And I think that's important for us as clinicians, especially when you're dealing with specialist care, which oncology tends to be the emotive bit, the specialist sort of medicines, the fact that, not everybody's understanding what's going on. But actually, for everybody that's seeing that patient, we must understand what the other person is going to be doing, what they're going to be saying, to bring reassurance and also to bring that consistent messaging as well. So that's something that, I'm very keen, and I know that the BOPA colleagues at BOPA are helping alongside with that design and really coming together. I think it's really sort of changing that whole narrative. And I think that's the only way forward, is to bring our patients in and follow them, and use their experience and their needs actually to help us to shape how we design the care that we need to, and I think I'm quite excited, very excited actually by that.